we're live, and mic number one. Hope everything's working, and it's all okay. Everything's okay. There's nothing to worry about. Everything's okay. The initial camera didn't work like it did last week, but we've got on this camera, on camera two, and we're live. And we've got some chitter chatter going on in the chat already, which is good. And it's all go. It's all kicking off. Right then. So we got what's this? Hello. Hi Sarah. PS, I'm 3 weeks post. Hold on, now I'm doing the wrong way around. Doing the questions the wrong way around. Rachel, could not get hold of that info regarding the BSAL, but it's also called Brazilian Lipo Aspiration, I think. Look it up for next week, maybe. Okay, yeah, I did look up BSAL. Brazilian Lipo Aspiration. I mean, basically, liposuction is liposuction, and there's loads of different types, because there was that other one, wasn't there, which I actually meant to put on the list of questions. I thought it was non-invasive liposuction, NIL, but it was actually new and something new sonic or something. So this Brazilian thing might be the same as this. There's lots of different types of liposuction, and basically I think the bottom line is look for your surgeon. Don't worry so much about the types of liposuction. They're assisted in some way. To be honest, we tend to use power-assisted liposuction, which means the machine goes backwards and forwards. There's others which are ultrasound-assisted, laser-assisted, and the new sonic one is some kind of ultrasound-assisted or something like that. So, but they're all variations of the theme, and I don't think there's anything particular you can do different with them, although they do say that you get skin retraction with some of those, which you don't get with the others. So that's something to look out for, but you need to look at their before and afters to see how significant that is, whether it's worth it. So Suzanne, hi, following a 6-hour op for tummy tuck and lipo, when is it reasonable to expect this overwhelming tiredness to go? Second question, if possible, following tummy tuck and lipo, when do you recommend returning to fitness, gym, activity and yoga? PS, I'm 3 weeks post-surgery. Suzanne, that is a long op. I don't think you're my patient. 6 hours lipo and tummy tuck, that's a long one. That is a long op. It's a long anesthetic, and that is going to take some time to get over that tiredness, Suzanne. 3 weeks is really early days, so don't worry if you're still tired at 3 weeks. Don't worry if you're still tired at 3 weeks. That's absolutely fine. Yeah, thank you.
Don't worry.
Thank you.
It's all good. It's all good.
So you, especially for, I mean, the tummy tuck is a big op in anyone, and with liposuction is, I'm on duty. I'm the only adult in the house, unfortunately. So my wife is away. Yeah, Freddie, can you leave, please? Can you leave?
Okay, I'll be on.
So I would say things, you'd probably be seen about 6 weeks. We normally see people about 6 weeks, and you'd probably be seen around then. You might find that things start getting back to normal at 6 weeks. 3 weeks, you can start getting into your fitness, activity, yoga. I think yoga, it sounds benign, yoga, but I think it can be quite active, can't it? So what I would say at 3 week mark, Suzanne, I would think it is good to start getting back into stuff like passive things like the exercise bike and the stepper, and just not too strenuous, and then nothing too active until that 6 weeks. And that's for a normal one. I think if you have a 6 hour op, that's obviously going to be a little bit more than a normal one. So
can you,
I wouldn't be
surprised. Choose what my hanger should be.
So I wouldn't be surprised if it takes a bit longer than that. So don't worry at 3 weeks, Suzanne. Sarah and Shona, hi. Deb, hi.
Which hanger?
Can we do this afterwards, please?
No.
Hi, Simone.
What do you do?
Right. So what I would do now is I would do my questions, which is the reason for here. That's why we're here, isn't it? Let's face it. So Suzanne, excellent. Thank you for that question. We got a question here, which I'm going to show. You know what? I normally have all. Here we go. Breast implants and pain. So this question here, I'm a 50-year-old female. I had breast implants 18 years ago under the muscle. Never had any issues and love them. 5 months ago, I started having breast pain diagnosed as mastalgia stroke chondritis. And NHS did a mammogram and said implants are fine, intact, and still soft. Anti-inflammatory tablets, cured for a few weeks, but now it's back. Should I have the implants removed? And will this cure the problem? This patient, I think, has actually been to the clinic at the weekend and saw Kuram, my colleague. So I'm not sure what he said. So I hope I don't contradict what he said, but this is what my view is. This is a tricky one. You sometimes do see people who complain of pain with breast implants, and sometimes people feel better when they are removed. So I tell this to people. I say, look, you do get people out there who have breast implants in and they say they're causing pain, and they feel better when they're removed. Usually breast implants cause pain when they've got a significant capsular contracture, which means they feel hard. Now you're saying yours are still soft. So if they're feeling hard, because they can sort of go rock hard after 18 years, then I'll be more inclined to say, yes, the pain is due to the implants. But if they're not, if they're soft, then I'd say from a sort of medical point of view, it's less likely to be due to the implants. And I would say that we couldn't guarantee that the pain will be improved if you have the implants removed. As I say, there is a very small, and it is very small, but they're out there, people who have had symptoms, including pain and illnesses related to implants, and they've got better when they're removed. So I think people often think implants are causing problems, but scientifically they haven't. There isn't evidence to say that they would or should cause problems, especially after 18 years. So I'd be very worried about removing them if pain is your only symptom. I think I'd be very worried about that, and I would probably suggest you see a breast surgeon, a surgeon who deals in the sort of breast pain side of things. That'd be a general surgeon rather than a plastic surgeon. A bit confusing, bit confusing because of the terminology there, which we can talk about in a minute. But yeah, a breast surgeon who would probably be a general surgeon who specializes in breast and would deal more with breast pain and what have you. But yeah, because you said you love them, so I think I would be very worried about removing them because it sounds like pain's your only thing. I would exhaust other options first. Can you go in another room?
What?
Can you go in another room, please?
Wait, is your thing gone?
Yes.
What thing?
Okay, this is regarding breast enlargement. This is another question. Sorry, yeah. Thank you, Freddie. Sorry, I'm not going well, is it? Right, next question, which I'm going to type in here. No, here. What is the likelihood of having to go under more surgery in the future, bearing in mind I'm only 22 and haven't had children yet? Further. Oh, geez. Sorry. Further. Okay, I need to put another. Right. So, good question there. Thank you for that. Likelihood of further surgery with after breast implants. Right, I'm going to ask that question. You know what? Last week I was so set up, I had all these questions typed in, and then the thing didn't work. Well, it didn't work this week either, but on my laptop now, I don't know if you noticed that. Oh, geez, give us my implants wrong. Question mark. Can we get a smiley face in? So we can. Not sure if a smiley face is appropriate, but it's in. What's the likelihood of having to undergo more surgery in the future, bearing in mind I'm only 22 and I haven't had children yet? There is a high likelihood of you having to go under further surgery if you are having implants age 22 and you haven't had any children. And yeah, high likelihood is the answer. So I would say you should plan to have at least another surgery, maybe 2, maybe 3, maybe more. And that is the problem with breast implants. We're doing loads of things. We're trying to, well, not doing loads of things, but always looking for ways of doing alternatives. Fat grafting is a great alternative because it's natural and you don't need any further surgery and what have you. But it's really subtle, the results, I find. So fat grafting is not quite there yet, because obviously if you're worried about having further surgery, fat grafting would be brilliant. Take some fat out somewhere and put it in your breast, and that's it for you for life. But it is not quite there yet, and that background's not good, is it? You got all my boxes, and so at the end of the day, what we've got is implants, and the chances are you probably will need further surgery if you've got implants in. The reasons you might need further surgery is if your implants rupture, obviously, but that is less likely than you would think, to be honest with you. I think a lot of people worry about them rupturing because these days they're made of cohesive gel, or they're form stable. So even if the shell fails, they keep their shape. So actually rupture's less of a problem because it can rupture. It's got silent rupture. You don't even know it's ruptured. Because it doesn't affect the shape of the breast or what have you. So rupture is less of a problem. Probably the biggest problem, I guess, is capsular contracture. The other problems you get is rippling and infection, but infection will only be early on. Particularly if your weight changes, your breasts can change. If you lost a lot of weight, you might get rippling of the implants. But I guess the big one is capsular contracture, hardening of the implant. I normally say it takes about 5 or 10 years for that to happen. And if that happens, you might want to have the change. Now, I've got to say, a woman who had their first implants in 55 years ago, or whenever it was, I still got them in. So you don't have to have the implants changed. They're probably really hard, but you don't have to have them changed. But for people thinking, especially you're 22 years old, you're thinking of having surgery, I would say in 5 or 10 years, they might start to go hard and you might want to have them changed. As I say, you don't have to have them changed, but you might want to have them changed. The problem with changing them is once you change them, that's a bigger operation than the first operation. It's more expensive than the first operation, and it creates more scarring because you cut out all the old scar tissue around the implant and put new implants in. And so another capsule or another scar tissue formed around the second lot of implants quicker than it did the first. So you want to leave it as long as you possibly can before considering having your implants changed. So that is probably the thing. But if you're 22, you're probably going to need more implants. So then you can think about things, and then you have to talk about the risks of implants and the complications with implants, because you got the polyurethane implants, which are much less likely to go hard. Is that a better look? How's that look? And you've got textured implants, which are less likely to go hard than smooth implants. But then you've got your ALCL, which is a type of cancer associated with implants. And there's no cases of ALCL with smooth implants, but the risk of capsular contracture is higher. So, oh man, it's a nightmare. So yeah, there's a lot to consider really. If you're 22 and you think of having implants, there is a lot to consider. I wouldn't take it on lightly. Lightly. So yeah, a lot to think about. Yeah, something to think about there. Does this look ridiculous? Put the mic down here. Get it all set up. Right. Next question. Is that all right? That question. What are the risks, complications associated with tummy tucks? Broad question. We'll answer it. So, risks. Is it risks or complications? Risks of tummy tucks. And that's an appropriate face. Thanks. That's an appropriate face. Okay. So, all surgery has risks. All surgery has, everything has potential downsides associated with it. Do I need to hold this? Is the audio okay when that's over there? Testing. Is the audio okay like this? Or do I need to hold this? Position 1? Position 2? I'm going to try position 2 for a while. So the risks of tummy tuck. So the risks can be associated with the risks of the tummy tuck itself, so specific to the operation and general risks, so the risk of any surgery, tummy tucks usually done under a general anaesthetic. They're very safe general anaesthetics, but there are risks associated with anaesthetics. You can both okay. They can. Oh, hold it. Sarah's saying hold it. Tummy tucks can so there's general associated general anaesthetic. You can have a reaction to the drugs they use in the anaesthetic. You can get things like DVTs, clots in your legs that can fly off into your lungs. These are risks with any anaesthetic or any operation. It's a little bit higher with the tummy tuck because you're making the tummy tight, so the venous drainage from the legs, the blood flow back from the legs is less, so you're more likely to get clots in your legs, and clots in your legs can fly off into your lungs, and that's a serious complication. That's a significant problem. So we do a lot of things to reduce that risk, and we try and get you up and walking as soon as possible. That's probably the big one, really. That's a really big worrying risk, really, of a tummy tuck is the clots in the legs. So we put stockings on, we put these things called Flowtron boots on, which blow up your calves. We give you heparin injections to thin your blood, and most importantly, we get you moving as soon as possible. And when you're not moving, I'd say to you, when you're in your bed, keep your legs moving, your ankles moving, keep all that blood circulating. So that's probably the biggest risk, really, of a tummy tuck. But as I say, that is a risk of any operation, although it's slightly higher with a tummy tuck. You can get chest infection, pneumonia, problems with any sort of surgery. Not quite so much with this sort of surgery, because usually it's on fit young patients who are usually pretty motivated, and they get up quite quickly and get up walking, get up and moving quite quickly. So then you've got your specific risks of the tummy tuck. And the first thing I say to people with the tummy tuck, well, with any surgery, is scar. Scar's not a risk, but it's a thing that you have to be. It's a what was the other thing? Risk to complications. It's not really a complication. It's it's going to happen, but you have to be aware of it. And it's a long scar with a tummy tuck, and there's also usually one around the belly button, certainly for a full tummy tuck. So the scar is one thing, is a risk, I suppose. Well, no, it's not a risk, but it's a thing that you have to be aware of. Usually pretty red to start off with, usually fades pretty well, but it can take a year or so for it to properly fade. So that's a thing that you have to be aware of. You can also get dog ears, little bumps at the end of the scar, which usually settle, but if they don't, you can fix them, but you have to leave it a few months because they often do settle on their own. But if they don't settle, you can fix them. Usually be done under a local anaesthetic. So that's a risk. In terms of complications, you can get hematoma, blood collecting inside, means it all balloons up. Have to go back to theatre and have it washed out. That can happen whether or not you use drains, and there's a lot of talk whether you use drains or not with tummy tucks, but whether or not you use drains, you can get a hematoma. So just because you use drains doesn't mean you're not going to get a hematoma. You can get a hematoma either way. Usually happens in the first day or so after the surgery, all balloons up, and you have to go back to theatre and have it washed out. It's not a massive problem. It's not very nice because you have to go back to theatre, but it doesn't affect the long-term result. The other thing is seroma, which is sort of watery. So hematoma is blood collecting, and that happens in the first day or so after surgery. Seroma is watery fluid. It's like wound fluid, which can collect in the space where you've done the tummy tuck. Oh, that's nice. Those lights have gone off. And seroma is a bit of a nuisance, really. It's not a big problem. It's water sloshing about in your tummy, and if that happens, you might have to put a needle in, or we would put a needle in and draw it off with a needle, and sometimes that needs to be repeated. So it's a bit of a nuisance, but it's not a major issue. You can get problems with the wound healing. So obviously the whole point of a tummy tuck is to make it as tight as a drum. You want to make it really tight to give you a really nice contour to your abdomen, but when you're closing wounds tight, there's a risk that they can open up a bit, so you might get little bits of wound healing problems. Quite a lot of dissolvable sutures in there. Sometimes you get little spots and little localized inflammation areas where the dissolvable sutures are. So that's a potential risk. And particularly in smokers, to the extent that if you're a smoker and you can't stop smoking, I would say don't have a tummy tuck, because whenever you smoke, you reduce the blood supply to the skin and you reduce the risk of wound healing. You reduce your chances of adequate wound healing, and so you've got a risk of a problem. Because it's under such tension, when the wound does break down, it can break down really badly. And the only really bad wound breakdowns I've ever seen have been in smokers. So I would advise you, if you can't stop smoking, to not have a tummy tuck. It's that bad. Other risks or complications, unhappy with the result? As I say, if it's too tight, you get wound breakdown. If it's not tight enough, you might say, it's not tight enough. There's a bit of redundant skin there. That's a risk. I mean, we're trying to give everyone the best result we possibly can, but there's always risks that, you know, we either do it too tight or not tight enough. Oh, look at that. Oh, oh God, I'm using the wrong thing. Oh, what's that? Oh, thanks, Deb. Yeah, so I don't get that from there. So yeah, sometimes the scar settles all right. So sometimes it works out well, but yeah, those are the risks of tummy tucks, I suppose. So not insignificant. Again, it's quite a big op. Got to really think about it, whether it's right for you, but it's you know, pretty informed of the risks versus the benefits. All about the risks and benefits. Which way does it go? You know, if the risks are higher than the benefits, then it's not a goer. But if the benefits are outweighing the risks, then it might be a goer. So yeah, good question. Doing well. Next question: what is aftercare is included? Are there guarantees regarding surgery? Big question. The aftercare stroke guarantees. Appropriate smiley. Right. So this is a big question, and I always tell people to think about this, because a lot of places will say you got a guarantee or you know, aftercare for 10 years or 5 years or lifetime or whatever, but you got to think what's included. So basically the things that you got to look at are the sort of coming to the clinic and talking to the doctor, talking to your surgeon, the having surgery, so that obviously if you're worried, you want to come and talk to the doctor about this, about your problem, about your worry. Then you got your surgery. Having surgery is going to incur costs. So how long are you covered or guaranteed in terms of that? And then if you have got implants, if it is a breast augmentation, I don't know what this is, but then obviously if there's implants or devices, the devices will have a guarantee on them or aftercare. So those are the things that you really got to think about in your own mind, and be comfortable in your own mind that you are being looked after. So I'll talk in general terms, not so much with what we do, but in general terms, what you've got to look out for if you're thinking of having something done. So after seeing the surgeon, sometimes people will charge for follow-up appointments. Some doctors charge for follow-up appointments. We tend to bundle it all in the price of the op, so you don't pay any consultation fees after surgery or before surgery. You come back and see the consultant as often as you want. It's all included at any time ever. You know, you come back 3 years later, 4 years later. In fact, even if you come back for a different procedure. So if you come for a tummy tuck and you want to talk about breast implants in a year or 5 or 10 years, we don't charge for a consultation fee if you're a current patient of ours. So, so that's one thing you've got to think of. If you're going to have particularly if you have a problem, you have to come back every week. You're going to have to be paying £100 every week to come and see the surgeon, sort of thing. It's going to be a bit of a bind. But or if you have just a bit of a lumpy scar or problem with something in a year or 2 years, are you going to have to pay to see the surgeon to chat about it? Number one. Number two is implants. I know I said implants third, but I'll talk about implants now, because a lot of people say I've got a 10-year guarantee and stuff, but that's just the implants often. So all the implants we use got a lifetime guarantee. A lot of implants nowadays have a lifetime guarantee. Not all of them, but a lot of them do. But then you've got to think, what does that cover? Because it usually covers rupture. So the guarantee usually covers rupture. As I said a minute ago, rupture is normally not as much of a problem as capsular contracture. So it doesn't always cover capsular contracture. Some companies cover capsular contracture, some companies don't. Some companies, so when I say that they give you a lifetime warranty against capsular contracture or rupture, that just means they'll give you a new implant. They won't pay for you to have it put in. So you've got to think, that's not that helpful, because the implant's only a few £100. And so some implants will give you both. Some warranties will cover both implants. Some will just give you one. So obviously, if you want to have the other one changed, if it's been 15 years, you want to have the other one changed. Some will allow you to have a size change. Some won't. Some will give you money towards the hospital costs. Usually, if it's a rupture, they will give you some money. $1,000 or something usually towards the hospital costs. Others don't. But then the ones that don't usually cover capsular contracture. So there's always a bit of a trade-off between the warranties. So the warranties are all, it's a bit of a minefield and it's a bit confusing. I think that's why you find a lot of people would just use the same implants because they sort of know what their warranty of the implant they use is, because it's hard to know what the warranty of Allergan and Mentor and Nagor and goodness knows what, Polytech, and all the companies have all got different warranties. So yeah, some will just give you an implant, some will give you money towards the implant, some will cover capsular contracture as well as rupture. So that's the implant thing. And then the surgery is probably the big one. I think when people talk about, oh, Dee, can you clarify what your aftercare covers with implants? Well, our aftercare here, specifically with the implants, well, not here. No. We tend to use Nagor or Polytech. Can use it any, if you want a different make, we can use a different make. But Nagor cover capsular contracture and rupture for life. So they cover both for life, but they don't give you any money. So they only give you implants. You have to pay for the hospital costs. Polytech cover rupture for life. They don't cover capsular contracture. I don't know why, because Polytech use polyurethane implants, which you've got a lot less risk of capsular contracture. So I wish they would cover it, but they don't anyway. But the risk of it is less. But the good thing, the thing about Polytech is that they cover you for 2 years. They will, you'll have the hospital costs covered. So talking about, am I rambling a bit? I hope I'm not. So the next thing you've got to think about is the hospital costs. So that's just the implant. They give you an implant. So what are you covered in terms of the hospital cost? So say if you have Polytech implants, they have well, it's not Polytech, it's Q Medical, who are the UK distributors of Polytech, offer a guarantee or a warranty, which covers you for 2 years, and that will mean that they will give you money towards the hospital costs. It's £1,500 per breast. We tend to just say that you're covered. So if it's more than that, we cover it. But basically means that you're covered for any surgery within 2 years of having the operation. That means if they're not sitting right, if they're sitting too high, too low, not quite sitting right, or if you get a seroma, or if you get a problem, basically, if they rotate, if they're teardrop. So that's Polytech. But then the hospitals have a sort of warranty. So the hospital, it varies between hospitals, so you have to check with the hospital. So with the 2 hospitals we use are BMI Priory and Parkway, Spire Parkway. BMI Priory in Edgbaston covers you for 6 months. Parkway in Solihull covers you for 12 months. That means if in 6 months or 12 months you have a problem, all the hospital costs are covered. You can have if they're sitting too high or too wide, or if you have a dog ear, say if you have a tummy tuck and you've got a dog ear, like the little bump at the end of the scar, or you get a seroma and you need to have it drained, or a hematoma and you have to go to the theatre, or anything like that, they will cover you, so you don't have to pay any of the costs. But if you need surgery after 6 months or 12 months, depending on which hospital, you will have to pay the surgical costs, the hospital costs. See, it's even hard for me to explain. I'm not sure if I've explained that well, but it's not as clear as I think sometimes people just like saying, oh, 5-year warranty, oh great, I'm sorted for 5 years, and you realize you just covered for the implants, But it's important to clarify. I don't know if I've clarified it very well there, Dee. I hope so. But it is a thing, the warranty. I think that's something that is, yeah. Happy to clarify that better if I haven't done very well there. So what we've got to go on now is, after losing weight, do I need to wait for a while before looking at getting my breasts done? BBA stroke mastopexy. So good question. Do I need to wait after losing weight? Oh, wrong there. It's the do I need to wait after losing weight? Huh. Kissing wink show. So, can I upload a picture for a friend? She's worried about her boob uplift. I don't know, Hamida. Can you upload a picture? Give it a go. Give it a go. We're getting interactive now, aren't we? Give it a go, Hamida. I'm happy to have a look at an uplift photo. If you would like me to, and if you can upload it, I'll look out for it. In the meantime, we'll ask about waiting with weights. I'm not sure how I can get a pic to you. Oh, nor am I, Hamida. Can you put a picture on? You could always direct message if you want, Hamida, and I'll do it afterwards if you want. If you people sometimes do that. I do see, or you can email it to us, info@steinoplasticsurgery.co.uk. But I've got to say, Hamida, if I'm assuming it's not my patient, if it's my patient, then obviously definitely you shouldn't come into the clinic. I'll see it. If it's not my patient, I would always, can I have your name? Jonathan is my name. If it's I would always say go back to your surgeon is always best, Hamida. On my PC. So my PC's in battery saver mode. That's good, isn't it? It's going well, this. So do I need to wait after losing weight? Yes, it's always good to be stable with your weight. So that is always a good thing, to be stable. Ideally, I mean, certainly when you're on the NHS, they want you to wait about 6 months or 12 months to have a stable weight, because if you change weight after having surgery, you can affect the results of the surgery, especially if you're having a breast implants with a lift, which is what this patient's talking about. So breast implants with a lift is a big op. It's quite a big deal. You make the skin really tight with a lift, you make it tight with the implant breast up here. But if you lose weight afterwards, you might lose not only volume in your breasts, so you might get the weight, you might get the size perfect for your body as it is now, but then if you go on to lose more weight, then they might be too small. Or if you put on weight, they might get bigger. So they can change if you change weight afterwards. So it's always best to be stable and comfortable with your weight. Particularly Donna, Hamida, I've seen your email, your message. I will answer in a minute. So I'm just trying to lose it. So Donna, just if you gain weight after a tummy tuck, what are the risks of developing loose skin again? The problem, Donna, is not so much gaining weight, is gaining and losing weight. So gaining weight is fine because you just put on weight, it's fine. The problem is when you gain weight, you stretch the skin, and as long as you stay with that weight, that's fine. But if you lose weight, so if you gain it and then lose it, the skin might not recoil. So you could spend thousands of pounds on a tummy tuck, and and then you could have loose skin again. So there's a chance of that if your weight fluctuates, which is why it is good to be stable with your weight, whether you're having a breast lift and implants or a tummy tuck. Any sort of body contouring, tightening procedure, when we do the surgery, we make it as good as we can for your current situation, for your current weight. If you change your weight in any way, as I say, putting on weight or losing weight, or worse still, putting on and losing, doing them both, that might affect the result. It might not. I mean, I'm not saying it's definitely going to affect the result, but it might affect the result. And so that's something to think about, something to consider. So it's always best to be stable, ideally 6 to 12 months stable. Certainly in the NHS, they have criteria for it. In the private sector, they have, well, certainly we don't have a criteria for it saying that you have to have a 6 month, documented stable weight. It's not as strict as that. But I think in general terms, I would say to you, if you want the best result possible, you're better being stable and comfortable and happy with your weight, and that's realistically a weight that you can be stable at before having surgery. So Hamida, Freddie, can you bring my battery, my charger for my computer? It's by the sofa in there. Right, it's by the sofa, Fred. It's plugged in next to the light. So gloss over that. I'm sure we can edit that out. You're welcome, Donna. So yeah, you don't, after a tummy tuck, you don't want to put on and lose. You want to be stable, ideally. So sorry, Hamida's got some questions here. Can I have your name, Jonathan? You've done that. Yes, she 2 weeks post-op and same different. Same different.
Why not?
No, Freddie, that's not it. What is that? What is that? Freddie, it's next to the sofa where you're sitting.
Where am I sitting?
Oh God. So my email is Hamida. My email info at styanoplasticsurgery.co.uk, or you can go to the website, or you can direct message me on the Facebook. Different shaped breast, and we're nipple sitting. Yeah, I mean, Hamida, I think probably it's. I'm gonna. If you think it doesn't look right, I'm probably going to say it doesn't. It doesn't. It's probably not right. So you'll. I think it's always good to go with your surgeon. I'm happy to give you an opinion, but I think it's always best to talk to your surgeon about nipples not sitting right. And did you say 2 weeks? I wouldn't worry too much if it's 2 weeks. Did I say that? I think it was quite soon, wasn't it? 2 weeks, yeah. 2 weeks, I wouldn't worry too much about it, Hamida. I'd give it time to settle.
Where is it? Okay. Where is it? Where is it?
Sofa. You know where the big light is plugged in next to the sofa? It's just there.
Which light? That one over there.
Okay, don't worry, Fred. It's all right.
That one over there.
No, Freddie, it's okay.
That one over there.
Yeah, it's only been 2 weeks, so that's all right. Thank you.
So off.
Is there anything to minimize bruising or swelling after breast implant? Minimize bruising after breast implant. Right. So sorry about this, everyone. It's okay. My wife's not here, so I'm the sole responsible adult here, and I'm not doing a very good job of it. I think you can clearly see that. My battery's running out of battery. My computer's running out of batteries. I haven't got the thing up. I'll just type that thing in, and it's gone. What was it? Bruising, swelling after breast implant. Question is, what minimizing bruising? Okay. Fine. Have it your way. It's not typing in. Fine. Have it your way, computer. See what I care. If you don't want to type it in, don't type it in. Fine. I'll just say it, right? Okay. Minimize swelling or bruising after breast implant. I'm a professional, and I'm trained to cope with these situations. I don't like that fuse box up there, so I'm going to do that. Okay. What can you do to minimize bruising and swelling after breast augmentation? I don't think you get that much bruising or swelling after breast augmentation. Well, swelling you do actually. Bruising is not normally a big thing. Sometimes you get a bit of bruising in the sort of in the area, like sort of cleavage, with a bit in between the breasts, but it's not a major thing really. So to be quite honest, don't tend to do a great deal for it because it's not a great thing. It's not a big thing. But if you are worried about bruising and things, there are things you can do. You can do heat and cold, and there's this thing called high-low care or hylotherapy. It's a cooling thing, cooling bra and all that sort of thing. People do after facelift and that stuff for the swelling and what have you. But as I say, I don't find that bruising is a massive thing. Swelling is a thing. You do get swelling. So what I normally do is suggest you wear a supportive bra, and it's good to wear that day and night for a month. So that does help with the swelling, does hold back the swelling. So I think that is good. People do use. I'm messing with the microphone now. I'm not messing with the microphone, Joni. I'm trying to there. Leave it alone. I'm trying to be professional. Leave it there. Right. So swelling is a bit of a thing. and so the bra I think helps with that. And people talk about using hot and cold ice packs and heat hot water bottles and things like that. But I always say be careful with those things, because if you have just had a breast augmentation, your sensation might be altered. So you can actually burn the skin up, both with hot and cold. You can burn the skin. So you've got to be a bit careful using hot and cold on it. If you're going to use ice, obviously wrap it in a kitchen towel or something. Wrap the frozen peas in a kitchen towel, because you don't want ice directly on the skin. So I normally actually say steer away from it. If it's really swollen or really uncomfortable and you find it soothing to use heat or cold, you can, but just be a bit careful that you can potentially burn the skin, because if you just had a breast augmentation, the sensation might be altered. So that is something to think about. So do you use drains for your surgery on tummy tucks or drainless? What do you consider best? I read that drains can carry more risks. Good question, Donna. Just going to get my charge up. I'll answer that question just quickly. Right. So yes, I do use drains, Donna. I do use drains. I do still use drains. I think that drains are good. I know people don't like drains. People don't like drains. But I think they are good for tummy tucks, because they close a dead space. Having said that, we are all moving away from drains. Where's the thing now? We are moving away from drains in most operations, and tummy tucks is pretty much the only one that I use drains in. Scarf. Tummy tuck is pretty much the only one that I do still use drains in, although I am trying to move away from it using quilting and what have you. So people used to use glue, and well, I think they still do use glue, and I worried about the glue. I think quilting is a better idea, sort of stitching the space down so it's sort of in pockets. So what I'm currently doing is quilting and drains, but I might move away from using drains. Watch this space, but I do still use them. I read that drains can carry more risks. Yeah, I mean, probably the big risk of drains is pain. People don't like them because they're painful, but I guess it's a tube going into the body, so you can get you can get infection when you've got a drain in and things like that, because it's a bit of plastic, so you don't want to have a bit of plastic in if you don't have to. It's a bit more of a worry with implants in breasts and things like that, but in tummy it's still it's still a bit of plastic foreign body, but you normally only have them in for a day or two, but 2 days anyway. But yeah, so Donna, the problem is there's two camps, and if you look at most plastic surgeons when you're in meetings, everyone's who use drains, who doesn't, like sort of 50-50, and so who's right? Because if one was right, the other one will be wrong. So 50, whole load of plastic surgery. So there's no right or wrong, and it's just what people have got experience in. But I think you will see it moving more away from drains, and I think we are be going that way. But at the moment, still you use drains. Can't just like the fact that a suction drain is closing down that space to reduce the risk of seroma and what have you, because it's got a very low risk of seroma in my practice. So that's why I still use them. Good question there, thank you. I think that went well. The getting the charger. So There you go, that's working. So would you use quilting instead? Yes, instead. So do use quilting, Sarah. Oh, look at you, Sarah. You're up there with the terminology, quilting. Hmm? Yes. So basically, use quilting and drains at the moment, but the people are saying that you use quilting instead of drains. As I say, a while ago, talking about using glue to stick down the thing, and I just worry that glue will be strong enough. So now we're talking about quilting, which we always did in the lat dorsi-donocytes at the back when we took a breast reconstruction. Quilting was common then, but now quilting down tummy tucks. There's a few things to be aware of when you're doing quilting sutures for the tummy tuck. You have to do it in a certain way so you don't splint the wound open. You're actually helping yourself to close the wound. So there's a few technical things about quilting, but so currently using quilting and drains, but it might be that as we start seeing less and less in the drains, we'll start saying, right, we're just going to use quilting and no drains. That might be the natural progress, but yeah, at the moment quilting and drains. So yeah, after losing, we've done that. Minimize swelling. What kind of help will I need during my recovery? It's a bit open. I think, but basically, got Sarah now who's doing videoing stuff, and I want her to do more videos seeing people after their surgery to see how they. Oh, what's that? Sorry, I'm not sure if that's the correct emoji. What is that emoji? They're crying. Sorry, doesn't mean crying one. I want to show people what people are like. So I think a lot of people think that people after surgery are sort of really debilitated. They're lying in bed and they can't move and they need to get someone to do their shoelaces up, sort of thing. But I don't think it's as bad. I mean, obviously it depends on what surgery. It doesn't say what surgery, but let's just say, you know, the breast surgery, body contouring, tummy tuck, that sort of stuff. I mean, they are quite big operations, but and you are quite knocked back. You do feel tired, you do feel jaded, but you don't really feel sort of debilitated. I think you'll still be able to do your shoelaces up and you know, potter around the house. You're probably not going to want to cook a big meal and things like that, but you'll be able to look after yourself. Yeah, it is nice if someone's there to look after you, but I don't think you absolutely need someone to look after you. I think you'll be able to look after yourself. You'll be able to wash and what have you, but it will be painful. Certainly the first few days, you will find it difficult to move and to get about, and you're going to probably be confined to barracks. You're going to be staying at home and, you know, not doing a great deal. After the first week, you start to feel better, and you maybe do doing some work from home on the computer and stuff. But the first week, you probably will find it tough, but you should be able to, you know, cope and survive. And if you've got some help at home, then so much the better. Again, the first few days, I think it is nice to have a bit of support, especially if it's a bigger op like a tummy tuck or a breast reduction or something like that. So, sorry about the emoji. I don't think that's the one I meant to use. It looked different when I put it on. Here we go. Is there a difference in cosmetic and plastic surgery? Yes, there is a difference. So basically, the difference is cosmetic surgery doesn't exist. That's the difference. Cosmetic surgery does not exist. Plastic surgery exists. Plastic surgery is a specialty, is a surgical specialty of its own right. You go through training. You become a surgeon. You then do 6 years of specialist training. So you do general surgical training to get your FRCS, Fellow of the Royal College of Surgeons, or MRCS, a member of the Royal College of Surgeons, and then you go on to do specialist training in a specialty in order to become a specialist. So when you are having treatment in this country, If you are having treatment in the NHS, you would be under a consultant. A consultant is a fully trained specialist. In the private sector, unfortunately, you don't have to be a fully trained specialist to treat people. In the NHS, your care will always be under a consultant who will finish their training or be a fully trained specialist. In the private sector, it's not like that. If you will get treatment in one of the major private hospitals, Spire, BMI, Ramsey, not Bupa, Nuffield, Winfield, anyway, I think there's one of the big private hospitals, you have to be a fully trained specialist to work there. If you get trained in a clinic or in not one of the major private hospital national private hospital companies, they can decide who they let work there, so they may not insist that you are fully trained. In order to prove someone's fully trained, it means they've hold or have held an NHS consultant job. If someone holds or has held a permanent NHS consultant job, then you can be pretty sure they're fully trained in a specialty. And the specialties are things like plastic surgery, general surgery, although general surgery sounds general, it's not. It's a specific thing, usually bowel, hernias and things, or breast, thyroid. Those are subspecialties of general surgery. Orthopedic surgery, ENT, cardiothoracic. There's a few surgical ophthalmology, few surgical specialties that you can be trained in, and you can become a specialist fellow with the Royal College of Surgeons, and then you get FRCS, and then brackets letters, for plastic surgery, or for orthopedic surgery. In letters afterwards what that training is in. There's no training in cosmetic surgery. There's no FRCS cosmetic. That's not a thing. Cosmetic surgery is just what people call it. Surgery, it's a subspecialty of plastic surgery, but a lot of other surgeons perform cosmetic surgery. ENT surgeons will do noses and ears, prominent ears. So lots of other surgeons will do, general surgeons will do breast, the breast subspecialty of general surgeons. So lots of other surgeons will do cosmetic surgery, but they may not be plastic surgeons. That may not be a bad thing, because if they're an ENT surgeon, they might be okay to do rhinoplasty, noses and things. But they're not plastic surgeons, they're ENT surgeons. The problem is a lot of people feel and think, thanks Junie, they think that they are plastic. They think that they're plastic surgeons when they're not. And sometimes people will put FRCS Gen, no, not Gen, that's general surgery. FRCS Ing, ENG, or Ireland or Scotland or whatever in brackets, but that just means that's where they got their FRCS. So you're looking for someone with FRCS and then brackets after their name, plast. If you're a plastic surgeon, PLAST, sometimes PLAS. So that means they're a plastic surgeon. If they haven't got FRCS plast, they are not a plastic surgeon. And if they've just got FRCS, they are not trained in anything. They haven't finished their training. They have just got general training. They haven't got specialist training. The other thing, you can look at the GMC website. If you know their hospital, if they know their GMC number, you can look at the GMC website, and you will see if they are on the specialist register. The GMC has a specialist register. So obviously all doctors are on the GMC, are registered with the GMC. You have to. That's after a year of qualifying, you become registered with the GMC. But it takes many, many years to become a specialist. And so the GMC have a specialist register. I think the problem with this country is this information is not that easy to find. The likes of hospital group use surgeons who are not specialist plastic surgeons. Thanks, Junie. Yeah, I mean, I think the problem is in this country, there's a lot of non-specialist plastic surgeons doing this sort of stuff, plastic surgery, cosmetic surgery. They're either not specialist plastic surgeons, so they're other specialists, or they're not specialists in anything. There's a lot of people who are not specialists in anything. Hold the bus. There's a lot of people who are not even trained in surgery. You don't have to be trained to do this stuff, unfortunately. A lot of doctors, GPs have got no specialist training in surgery. They could set up shop and start doing liposuction and doing goodness knows what else they want to be doing. So that is the problem. That's why I've written my book. Got it in the background. Have you noticed that? Product placement. Never accept a lift from strangers. That's why I've written my book, Never Accept a Lift from Strangers. How to choose the best plastic surgeon for your cosmetic breast surgery. Jonathan Stiano, that's me. See the letters there? FRCS Plast. See FRCS Ing. Oh, I can't hit center. So it is very scary. It is very scary, Deborah. It is. So that is the problem with the training, that a lot of people call themselves plastic surgeons, or worse, well, not worse still, cosmetic surgeons. And cosmetic surgeon doesn't mean anything really. It's just they're just using that term. Plastic surgeon is a thing, and the problem is a lot of people who aren't plastic surgeons are still calling themselves plastic surgeons. But that is excellent. Thanks, Junie. So, Junie, you've got a botched surgery support group. God, dear, oh dear. So that is a problem. The problem is a lot of people only realize this afterwards. They afterwards think, hold on a minute, he wasn't a plastic surgeon. Oh my God, he wasn't trained in anything. And he's a GP, or he's a goodness knows what. He's an A&E doctor or something like that, you know. So yeah, there's plenty of plastic surgeons around. FRCS Plast is what you're looking for. That's what you want to make sure you've got a plastic surgeon. FRCS Plast, specialist register for plastic surgery. If you really want to get into it, go to the GMC website, put in their, if they've got a funny name like me, you can just put in their name. But if not, then you can put in their GMC number. We're all encouraged to share our GMC numbers. 411-7214. That's my GMC number. But if you find a surgeon, and you should be able to find his GMC number or her GMC number. But yeah, I guess the easy thing is FRCS Plast. That's what you're looking for. But that's a good question. And it is a scary thing. It's a scary proposition, and it's a problem we've got. And because we all talk about it when we go to these meetings and all legislation, and there should be a law about it, and we shouldn't let people not do this and that. I think get a law about it is a big deal. For me, I think the most important thing is to educate the public. That's why I do this sort of thing. That's why I've written the book. Just give it free. I think you can get it free from. Can you still get it free on Kindle? I don't know, but it's. I'm trying to. If you come to the clinic, we'll just give you a copy of the book. If you order it, I think we do a postage and packaging. But if you come to the clinic, we'll just give you a copy. Just because I think it's up to us as fully trained surgeons to get the message out there to people so they can make an informed decision. As I say, there's nothing wrong with an ENT surgeon doing cosmetic surgery, or a general surgeon doing cosmetic surgery, as long as you know they're an ENT surgeon or a cosmetic or a general surgeon or an A&E doctor or a whatever surgeon they are. And then you can make a decision as to whether they're, you know, you still look at their qualifications and look at their patients and look at their, you know, their results. And if they're doing a good job, then that's fine. So, you know, that's so what's Junie saying here? Full of people conned by general surgeons abroad and in the UK. I've learnt my lesson, so to pass it on as many people as possible. I know. And the problem is, Junie, they only find out afterwards, because afterwards people do all this research and they think, hold on a minute, that person wasn't trained. But, you know, Junie, we have got Shelley is a fan of yours. Your group is amazing. Keep up the good work, Junie, with your group. But yeah, you just, I think the problem is, and we talked about this at the last BA'S meeting, in America, you've got something called board certified. So if you go to any American websites, they all say, look for a board certified plastic surgeon, board certified, board certified. In this country, we haven't got something called, we should just call it board certified, but it's not called board certified. It's called FRCS Plast. And that doesn't sound as good, does it? Look for an FRCS Plast surgeon. Doesn't sound as good. But that's what it is. FRCS Plast is what you're looking for. Someone who holds or has held an NHS consultant job. As I say, if you go to the BMI, the Ramsey, the Nuffield, the local private hospitals, you can't work there unless you're fully trained in a specialty. May not be plastic surgery, but you're fully trained in plastics in a specialty. The problem is a lot of the companies, they have their own hospitals. And so if the company, like the cosmetic chains, if they got their own hospital, then they can choose who they have there. So they don't necessarily have to have people who are up to the same level as an NHS consultant. So they can have people who aren't trained or trained in other specialties. But that's what we're up against. So yeah, it's all about educating people so they can make an informed decision as to what's right for them. That's the bottom line. That's what it's all about. So I was just getting my email up there to see if I got that got that photo
from Hamida, but I haven't got it yet, Hamida. So I will look out for it on my email of your friend, and I'll put my aura in. But as I say, it will mainly be. Has it gone to junk? No, it's not gone to junk. It will mainly be going to your surgeon, I would say, Hamida. But I will definitely give a help and give my opinion on it. Oh, sorry, Tracy. Oh God, what's going on? You could tell I was about to leave then, couldn't you? What have I done? That's scary. I did see something. Question: Benelli or traditional? Good question. Look at that. We're getting technical now. Benelli. Where is that question? Jenny, here we go. You need that mic. Yeah. How similar? Hold on a minute. Donna's got in here. So how similar is the recovery on a tummy tuck to a C-section? I will do the Benelli question in a minute, Tracy. Similar. It is similar, Donna. Normally, I think it's similar. A C-section, they cut through muscle. A tummy tuck, you don't cut through muscle, though you might need to repair the muscle. So in that way, a C-section is worse because you cut through the muscle. But a tummy tuck, you're actually cutting skin out and closing under tension. Obviously, with a C-section, you're not cutting any skin out. It's not closed under tension. So in that way, a tummy tuck's worse. So I think on balance, it's about the same. I think they sort of. Oh, sorry, I should put that question up. Oh God. So on balance, I think they're about the same. I think they're the C-section is pretty bad because they cut through the muscle. Tummy tuck's pretty bad because you're cutting a tension out of the skin and you're sort of all crunched over. So it's pretty similar. I do think it's bad when they cut the muscle. I think that is really painful when you cut the muscle every time you cough and everything, it hurts. Now, as I say, with the tummy tuck, you often have to repair or bring the muscles together, repair what we call the divarification of the rectus muscle. We bring them together. We don't actually cut them. We actually sometimes do suture them to bring the gap between them together. So that can be a little bit uncomfortable when you cough and everything. But it's not quite as bad as the C-section where they cut through the muscle. So I think pretty similar. Maybe tummy tuck's a bit better. I don't know. But I think I would say pretty similar just to be safe. Sorry, Tracy, I missed your question. Benelli breast lift or traditional breast lift, what's best? Boom. Tracy, if one was best, the other one wouldn't exist. So it's hard to say what's best. I will tell you what I think, in my view. Personally, I don't like the Benelli. Tracy, I've said it. I don't like the Benelli. So basically, for the folks at home, what we're talking about here is a breast lift. So a breast lift, the nipple goes from a low place to a high place. So you move the nipple. There's lots of different ways you can do a breast lift. And a lot of the things, certainly for patients, what they worry about is the scarring. So the pattern of scarring is different for the different ways. Now, because you're moving the nipple, you pretty much always have to give a scar around the nipple because the nipple's being moved. So you can do it with just a scar around the nipple, which is the Benelli, which is like a donut mastopexy. So you take out a donut of tissue and then you just cinch it in. So you make a big circle into a small circle, a bit like when you do an areola reduction, to cinch the skin in and tighten the skin. And that just leaves a scar around the nipple, no other scars, which is great because I say around the nipple, around the areola, because that heals pretty well. And the interface between especially if you've got quite a dark areola, it can sort of fade in and you can't see the scar. The problem with it, so the next way you do it is you make a scar around there and a scar going straight down. That means you can tighten skin in rather than just doing a bunching, circumferential bunching. You can make a straight line down, lollipop scar they call it, or a circumvertical, where you can actually tighten the skin in this direction, or you can get an inverted T where you tighten it in this direction and that direction. So increasing scarring. So if you ask anyone, what do you want? They'd all say, I want the least scarring, please. I'll just have, no scarring ideally, but if we've got to have something, I'll just have the one around the nipple. Thanks very much. I don't want the others. Obviously, they're going to say that, but it's less. You can take less skin out, and it's less. The skin's off. The scars often puckered, and it sort of flattens the breast. It doesn't give the breast good projection. It flattens it, and I don't think it goes a good shape, and I don't particularly like it. The only time I ever use it is in men who I'm cutting skin out. And I don't use it that often, for a gynecomastia. Sometimes if there's a tuberous breast deformity, I might use it, but very rarely. Usually I'll put that other scar in, so the circumvertical, to take out skin in the side-to-side direction. Now, it does give that lollipop scar, which is slightly more obvious because you've got a straight line going down, but it's a much better shape. And after all, that's what you're having the surgery done. You want a shape. And in my hands, I'm just saying what's in my hands. Some people out there are going to say, oh, I love doing Benelli and I've got great results, and look at these before and after photos. Well, that's fine. Then we're all different. But in my hands, I think the circumvertical, and in fact, I usually convert it to a small T because there's usually a little bit of extra skin at the bottom. I convert it to a small T. Or if there's a lot of skin, a big T, the more scarring, the more skin you remove, so the more of a lift you get. So Tracy, my opinion on that is that I think I don't personally think the Benelli lift gives as good a lift as the circumvertical stroke lollipop or inverted T. So in my hands, I think the extra scarring is worth it to give you a better shape. But as I say, there are people out there doing Benelli, so they would argue against it. I think they'd argue that you couldn't get as good a lift, but they would probably say you get an acceptable lift, and in some cases it's good. But that's just me. That's covered that one off. Right. Listen, if anyone's still there, I really apologise about the shambolic state of today's show. Oh God, what have I done? Tracy's had the Benelli. I now have a bigger areola than before by far. Well, the Benelli relies on the cinching of the areola, so it depends on how you cinch that areola down. If you use a permanent suture, fine, but if you use a dissolvable suture, it can recoil up and it can stretch because you take that donut out and all of the lift is on that cinching of the skin. So that's a risk of a Benelli. So yes, Tracy, that is a risk with a Benelli. So yeah, sorry to hear that. So you could have an areola reduction with a permanent suture to prevent that happening. But then there's risks of permanent sutures because if you feel the knot and all that sort of stuff, you'll always be able to feel the knot if it gets infected. So there's bad things about using a permanent suture, but that is a risk when you're doing that donut because it's obviously closed tight. And if you use a dissolvable suture, it can ping out and stretch. So that's risk of Benelli. Sorry to hear about that. So yeah, I think that's that. I better go and look after my family now because I've neglected them until this point. So, oh God, turn that off. Had the knot snipped. Oh, you had the knot snipped. Oh, because you felt the knot. Oh, so it was okay. So was it a permanent suture and you had it snipped? Is that when it? Swings and roundabouts, isn't it? Funny old game, this surgery, Lark. I tell you, it's difficult to know what to do. Try and do something, then you snip the knot and areola stretches, and cure one problem, create another. Funny old game. Always trying to do the best. I'm sure your surgeon's trying to do the best for you, Tracy, and will continue to do so. So there are always things you can do. Those things will have risks and benefits, but hopefully they'll try and see you through. So good. So yeah. So that is it. I'm going to check out if that's okay. Oh, sorry, I didn't really do that. Yeah. So I am signing off and going to see what carnages are there outside. Thanks for coming, and I will see you next week, Tuesday at 7 o'clock. I'm looking forward to it already. Any questions, email, text, Facebook, Twits, whatever, get them in, loving it. Rachel, listen, thank you. All right, check myself out. Bye.